Good morning, good afternoon, and good evening. It is with great pleasure that I welcome you all here today for this webinar on gaining new insights into PAD and diabetes using optoacoustic imaging. My name is Mia Kavarusic. I'm the Medical Affairs Associate at Ithera Medical, and I will be moderating this session. We have two speakers today, Dr. Angelos Karlas and Dr. Ulrich Rother. Dr. Karlas will present first, followed by Dr. Rother, and the Q&A session will follow the second session. A little bit about Angelos Karlas. He studied medicine and received the MD, but also holds an advanced degree in electrical and computer engineering, both at the Aristotle University of Thessaloniki, Greece. He holds a Master of Science in Medical Informatics from the same university and a Master of Research in Medical Robotics and Image-Guided Interventions from the Imperial College of London, UK. He is about to finish his clinical residency at the Department for Vascular and Endovascular Surgery at the rechts the Isar University Hospital in Munich, Germany. He is also the tenure track group leader of the Interdisciplinary Clinical Bioengineering Group at the Institute for Biological Medical Imaging, Helmholtz Center München, Germany. He completed his PhD in experimental medicine, and he is currently a medical doctor and lecturer candidate at the Technical University of Munich. His main research interests are in the area of vasometabolic optoacoustic imaging and sensing, AI-based disease biomarkers, as well as robot-assisted and image-guided vascular interventions. With that, I hand it over to you, Dr. Karlas.
Thank you for the nice invitation, for the introduction. As Mia said, I'm Angelos Karlas. I'm going to talk about a work that we published recently, which gives some insights about how to use optoacoustics within the field of diabetes-related microangiopathy. So the title of the talk is Artificial Intelligence-Powered Optoacoustics of a Diabetes-Related Microangiopathy. Why diabetes? We all know that it's a very important health problem. Almost 400 million of people are affected, and unfortunately the rates are going to be like higher and higher over the years. Diabetes is coming with a lot of complications, with, of course, all the catastrophic results on the lives of the patients, their families, and also the health systems in terms of economic burden. Diabetes is a very complex disease. Of course, there are many types of diabetes, but generally it's a very complex disease. Its pathophysiology involves many different organs. I'm not going to get into detail. This slide only shows the complexity of the disease, how many organs are somehow affected. And as I said before, diabetes comes with complications. The major complications of this disease come in the vasculature, both in the macrovasculature or the microvasculature. Macrovasculature, generally, we talk about larger vessels above a diameter of 200 micrometers, and microvasculature in vessels where the diameter is less than 150, 200 microns. There are studies associating diabetes with these diseases like many decades ago published. It's nothing new. The main macrovasculature disease in diabetes affects, as we know, the brain, the heart, extremities, and the microvascular complications refer mainly to the eyes, to the kidneys, to the peripheral nerves, but also the skin. So the skin is also affected. There are studies generally in the last decade showing that microangiopathy affects the skin. There are also studies showing that the vasculature, the microvasculature of the skin is affected early in the course of this disease, so that we thought it's a very good idea, since we have very nice tools to scan the microvasculature of the skin to see what we can see in diabetes, what changes we can detect, and how this can be correlated with other markers. Of course, to assess microangiopathy in general in diabetes, optoacoustics is not the only technology. We have several different imaging and sensing technologies which are used nowadays, like the ultrasound, the magnetic resonance imaging for different organs, of course. Not all of them are used for each organ. The near-infrared spectroscopy, OCT for the skin, for the eye, different optical imaging modalities where we get photos of the eye microvasculature, and we get also insights into the progression of disease. Optical techniques for the skin, like the laser Doppler imaging or laser Doppler, let's say, fluorometry to check the skin, but not all of them give very nice images of the microvasculature with resolutions that I'm going to show now about optoacoustics. What is optoacoustics? It's a phenomenon which is, of course, not new. It was described first like several years ago, many years ago by Graham Bell. What happens during this phenomenon? We talk generally about the production of sound as a response to light absorption. So finally, with optoacoustics and in our machines right now, this phenomenon has been, of course, described many decades ago, but has been used in medical and biomedical applications for imaging and sensing of phenomena during the last decades. So in optoacoustics now, with the systems that we have, we use lasers with pulses, very short pulses of some nanoseconds, 10 nanoseconds, for example. We send these pulses in the tissue, in the material that we want to scan. These pulses are absorbed by tissue based on the optical properties of the tissue, something that has a color, as you understand, can absorb light. And these tissues which absorb the light pulses and their energy somehow get dilated, very small dilations. We call them thermoelastic expansions. These phenomena happen very fast at rates of 25 hertz or to 100 hertz, or 100 times per second. So finally, if you think about that, these very short pulses being absorbed and causing thermoelastic expulsion very fast, somehow we cause a vibration in tissue. And this exactly vibration is the production of mechanical waves. So from electromagnetic waves, from light, we go to mechanical waves, acoustic waves, which are propagated tissue. And these exactly waves, mechanical waves, we sense with ultrasound or sound detectors, and then we create images. So finally, we are listening to light, really. These images that we get are physically produced by sound, so we sense sound, but this sound shows absorption of light. All this phenomenon, of course, happens very fast, and because we have very fast pulses, then we get also modulated, somehow not modulated, but very fast waves of ultrasound, so that finally the frequencies that we get in ultrasound lies in the field of ultrasound, and that's why we use detectors in this area. I'm going to give more details about frequencies, etc., in the next steps. Generally, this phenomenon that I described is used in many different systems, not only the system that I'm going to describe, ARSOM. I'm sure that Dr. Rother will talk about EMSOL as well. But this phenomenon is used in many different systems with many different characteristics, either commercial systems or non-commercial systems. I had the luck to work with all different scales of detail, as we say, in these systems. There are thus microscopic systems with resolutions of 0.5 to 1 micron. There are mesoscopic systems, the ones that I'm going to talk about, that we use for the skin, with resolutions of 7 to 10 microns, and of course, macroscopic systems with resolutions of 100 to 300 microns. Of course, the depth changes with resolution. The ARSOM technology that I'm going to describe is going up to 2 millimeters, 1 to 2 millimeters in living tissue. So we talk about the human skin. Other technologies like EMSOT goes deeper, some centimeters, and microscopic techniques goes even in shallower depths. So in this study and in this, let's say, disease now, microangiopathy in diabetes, as a reminder, we used the raster scan optoacoustic message. This is the ARSOM technique. I had also the luck to work on the prototype when I was a student. And now there are commercial systems, as you know. This technology uses green light at an excitation wavelength of light at 532 nanometers. And it really raster scans a region. So there is like a probe which is adapted on the skin. It's non-invasive, of course, and it scans, it sends pulses of light, and it gets, as I said before, ultrasound waves back. And for its position, as I show here in this network, we get signals which are then reconstructed into images, 3D images, volumetric images, and then these are projected, and we get these very nice images of the skin. What you see here is a tomographic image of the skin. You see the EDs, the epidermis, the dermis. The different colors are simply different sizes of objects. So we talk about here absorption of hemoglobin mainly at this wavelength. So the different lines that you see are different blood vessels, with the larger blood vessels being red and the smaller blood vessels being green. Diabetes microangiopathy. So as I said, it's one of the main complications affecting eyes, etc., etc. But we thought in this study also, could we use the skin as a window or keyhole to disease? Could we see things in the skin with ARSOM that could be correlated with other complications of diabetes and somehow characterize the progression of disease? So this work was published a month ago in Nature Biomedical Engineering as a clinical study. I was also honored to be in the front cover. Here's the whole team of the University of Munich with Professor Giachristos, Professor Hazelodiadis from Khalifa University. What did we do here? So we scanned 150 participants, 40 healthy volunteers and 75 patients with already diagnosed diabetes. We performed these ARSOM scans on the skin. We segmented the microvasculature in these images automatically. We characterized this microvasculature by extracting features that describe it. For example, the vessel angle or the vessel length or the vessel number. I'm going to show what I mean about. And then we applied AI, there is a step, to select some of them which are supposed to be more correlated to the disease, more diabetes related, because they give more information about diabetes. And then with these features, we also conducted a part where we showed that these exactly features also change with diabetes progression. A small pipeline here. We see on the left the images. As I said, we segmented first the layers of the skin, epidermis, dermis, then we got the microvasculature out of it, especially in the dermis. We skeletonized the images. We found the microvasculature, we kept it, and we extracted features which describe it. And finally, with AI, with machine learning, we gave a score to each image or each patient so that we could say, okay, you have a good microvasculature or a bad microvasculature based on what I will describe next. The main point of the study is that we didn't use features. We could always, in AI, as you know, we could always give images and say, okay, decide if somebody has diabetes or whatever. But this doesn't give us any insight about where this decision lies upon. So the algorithm could give us some, of course, decisions, but we could not know if this decision really comes from characteristics of the vasculature or, for example, non-explainable features like the intensities or the variance or wavelength decomposition techniques. There are many studies out there showing this kind of things, but this doesn't give any explainability and any translation to the clinic. Doesn't give us clinician any insights about what's the problem there. That's why we analyzed the microvasculature before giving it to the algorithm, so that we have finally a clinically explainable approach. As a first step, we got the images, we analyzed the microvasculature, we selected the 32 features, and we selected them in a sense where the algorithm said, okay, these 32 features, the number of vessels, number of junctions, the layer thickness, I have everything here. It's not the point to get in detail about the features, but you have to understand that they describe this microvasculature. Okay, if you decide to keep only these, then you have the best classification between healthy volunteers and patients with diabetes. So it means that these features are more related to diabetes. As a first step then, as you see here, we performed this classification. We could say from the arsom image, only from the skin, if somebody has diabetes. Of course, this is something that it's done, and it's not very exciting. You don't need to scan the skin to say somebody has diabetes. This you can do with a simple blood test. That's why we went some steps further. Here we see some subgroup analysis, but we see that we have very nice classification rates, even if we subcategorize the patients. Let's say if somebody had higher HbA1c or cardiovascular disease or whatever, so the detection and the progression of disease was really high, which means that we didn't have any confounding factors there in the decision of the algorithm. So when we saw that at least arson can show us if somebody has diabetes, so it meant for us that we are going towards the right direction, and that this is a good application. So we further categorized, and this is the main thing of the study, we further categorized our participants with diabetes in 3 different classes. So we got patients with diabetes, but without neuropathy as a characteristic microvascular complication, or atherosclerotic cardiovascular disease as expressed in coronary artery disease, peripheral arterial disease, and carotid artery disease. So diabetes without complications. Then we got also a group with diabetes with neuropathy or atherosclerotic cardiovascular disease, and patients with diabetes with neuropathy and macrovascular disease. And we saw here as a classification that we got, again, very nice rates, as you see with this confusion matrix, very nice classification rates, so that algorithm could really categorize the subjects into one of these 3 classes. So we could have some insights about progression of disease or the complications of the disease through the skin. This is how we believe that the skin could be used also as a window. But the most important part for us was exactly how this decision was achieved. So, and this is where the scientific discovery in our opinion came. So we gained some knowledge about the disease. We further categorized, finally, here you see the nice image of the skin, the features that we extracted into 3 different scales of detail. So the macro scale features, which talk about somehow rough characteristics of the skin. For example, the skin layer thickness, or the general intensity of the vessels. Things like that are rough descriptors of the image area. Mesoscale features, which are, we talk about features which describe small neighborhoods of the skin, or as the organization of the microvasculature of the skin. For example, the number of joints, or number of vessels. How let's say, how many vessels do we have? How thick is this network? And of course, micro features, where we talked about single features, single vessel features, like the diameter of small vessels, the length of them, like a more microscopic view. And we saw that the decision for the detection of diabetes first was driven mainly from the mesoscale features. So that the mesoscale, so the organization really of the microvasculature in 3D space was really important for this decision, for this classification. And going one step further, we checked also about the progression of the disease. And we saw also for the second, we showed also for the second classification that really the mesoscale, so the organization of the microvasculature was also the critical parameter. So in this study, with the use of ARSO, we had many, let's say, solutions for different things. So we solved, we think, some things. It's a first study, of course. We need more studies, etc. This goes without saying. This is how research works. So we gained knowledge about the disease, that the mesoscale, the organization of the microvasculature matters. We could achieve disease detection, diagnosis. We all know how this is very, very important for everyday practice through the microangiopathy score. And we also somehow achieved disease staging, which could also be used for therapy assessment in the future, like using the skin as a keyhole to systemic disease. With this, I would like to thank you very much. Here is our group. We are in Munich, Technical University of Munich, and the Institute for Biological and Medical Imaging. Director Professor Gia Christos, and he is the Clinical Bioengineering Group. And with that, I would like to thank you very much for your attention, and I'm open to any questions.
Brilliant. Thank you very much, Dr. Karlas. It was a really great talk. I took back the controls for the webinar now, and we already have some good questions coming in, but I will save those for the Q&A session at the end of this webinar. That said, I would like to introduce our second speaker, Dr. Ulrich Rother. Dr. Rother is leitender Oberarzt, or the equivalent of the chief consultant in the vascular surgery department at the University Hospital in Erlangen. His clinical interest and expertise include vascular surgery, renal disease, hemodialysis, endovascular surgery, and renal failure. From the research side, Dr. Rother has published prolifically on microperfusion and various methods of assessment, including fluorescence angiography, O2C, and optoacoustic imaging, as these methods compared to gold standard techniques, but also outcomes following different surgical or endovascular interventions in PAD patients and walking exercise. Dr. Rother is also a co-author of the 2024 European Society for Vascular Surgery Clinical Practice Guidelines on the Management of Asymptomatic Lower Limb PAD and Intermittent Claudication. Okay, Dr. Rother, over to you.
Yes, thank you very much. And thank you for the possibility to present today my results here and for organizing this webinar today. I want to talk today about peripheral artery disease. Peripheral artery disease is an affection of a peripheral artery, mainly affecting the artery intima layer and the medial layer. In most of these cases, this leads to a stenosis due to arteriosclerosis. The clinical context then is a malperfusion in the distal region of this stenosis, leading to either walking impairment if, for example, the calf muscle or the muscle of the upper leg is affected, or in more severe stages to rest pain or ulceration of the foot or the toes. If you want to bring this into a classification, you can use the Fontaine classification, which is in the European area used for classification. At stages 1, you have asymptomatic patients. However, these patients are already affected by arteriosclerosis. And in the stage 2, it's called the intermittent claudication. You mainly have issues like walking impairment, either about 200 or below 200 meters of walking distance. Then you have an affection of the perfusion of the calf muscle, for example, and this leads to rest of the patient for resolving the perfusion again. Then in the more severe stages, it's called the CLTI stage, the chronic limb-threatening ischemia stages, subsumizing stage 3 and 4. At stage 3, you have rest pain, mainly during night. Patients report of awakening due to pain in the leg, or in stages 4, ischemic ulcerations of the foot or gangrene. So in stage 3 and 4, the leg is at risk, and you have to do something to establish reperfusion. If you want to see what happens in the future to our society, you can look at this publication here, which has recently been published in the European Journal of Vascular Surgery. In the future, you can see a propagated increase of the incidence until 2030 or even 2040 in terms of the incidence of PAD. However, after 2030, a decrease of maybe the mortality. But if you go more into detail, what kind of patients are affected, you can see here in this publication that PAD is mainly a disease of the elderly population. However, also in high-income countries compared to low-income countries. So it's not only an issue of low-income countries, it's also an issue in our high developed societies. And those patients you're seeing during your daily routine in the clinics, it's only the upper part of the PAD iceberg, as you can see here. These are the very critical ill patients, like the CLTI patients with gangrene or ulceration of the leg, and those really affected by intermittent claudication and a really decreased walking distance due to calf muscle pain or upper leg pain. All beyond the surface of the sea, there is an amount of patients which is undiagnosed or treated conservatively and maybe not adequately treated. This is of really high interest, as obviously PAD is not only a disease which affects the leg. You always have to see the entire patient, as patients who are suffering from PAD often also have problems of the carotid arteries, but also of the coronary arteries. Therefore, PAD, it's called a risk modifier, which elevates the risk for suffering a heart attack or a stroke in the future. Therefore, early diagnostic is really essential. If you have a look on current approaches of diagnosis, it's mainly established by a palpation of pulses. First, the femoral pulses, popliteal pulses, and the foot pulses, posterior tibial artery or dorsalis pedis artery. If you feel pulses in the periphery, you nearly can exclude peripheral artery disease. However, if you don't feel any pulses, you have to be sure that there's no PAD present. Then next step would be to do an ankle-brachial index, measuring the pressure on the level of the blood pressure on the level of the ankle, in the level of T2 arteries, and again on the brachial artery. Then doing a quotient out of it and calculating an index. It's called the ankle-brachial index. And if you go through this slide here, it's a recommendation out of the current guidelines for peripheral artery disease diagnostic. If you have a suspicion of a CLTI, namely an advanced stage of PAD, you have to do your examination doing pulse palpation and an ankle-brachial index, as you can see here. If the ankle-brachial index is normal, but you have a tissue loss or a gangrene, you have to go forward to be really sure that there's no PAD present. If it is below 0.9, it's proven that a peripheral artery disease is present in this patient. And very difficult to interpret are these values with ankle-brachial indexes above 1.4. It's called a medial sclerosis, and therefore you have an inconclusive ankle-brachial index, and you cannot use this kind of diagnostic criterion in these patients. Then you have to go forward doing additional measurements, which are in some terms difficult to establish, and there are different options. But in most of the cases, next step is then an angiography, like for example MRI, CTA, or a DSA in the end. Therefore, there's a diagnostic gap, especially in those patients with a normal ankle-brachial index and a suspicion of an PAD, as well as in those with an elevated inconclusive ancobrachial index like the medial sclerotic patients. And the problem is that most of these diagnostic approaches really focus on macrocirculation. You're trying to measure the big vessels by duplex ultrasound or ancobrachial index, but currently, until now, there's no diagnostic modality to assess the perfusion in deeper structures, like, for example, the muscle in the bedside setting. Therefore, in our study group, we try to use multispectral optoacoustic tomography, the MSOT. Dr. Karlas already reported in the cohort of the PAD patients. The principle was already described by Dr. Karlas, and therefore I'm not going again into detail. However, what we focus on the quantitative information we can get out of these measurements. We can draw regions of interest in pictures. We can see in the combined method of the ultrasound in the structures of the muscle, and then doing a quantification in these regions of interest, mainly focusing on hemoglobins here, like oxygenated hemoglobin or deoxygenated hemoglobins. First was a quite exploratory cross-sectional study we tried to perform. We suggested that maybe between healthy volunteers, claudicants, and the very severe patients, we might see differences in terms of calf muscle perfusion. Therefore, we had two study cohorts. One was the derivation cohort, and then followed by a validation cohort, each consisting out of about 100 patients, in total 220 patients. And we investigated the ancobrachial index, the walking distance, and MSOT of the calf muscle in all these patients. And what we have seen was quite interesting. We have seen already in the resting position of these patients in the different cohorts. Here you can see the healthy volunteers, here the claudicants, and here the critically affected CLTI stages, that already in the resting position, the calf muscle perfusion, namely the oxygenated hemoglobin that we measured quantitatively in the calf muscles. Here you can see the ultrasound pictures and the drawn regions of interest differed significantly between the stages. With then quite acceptable AUC, we found a difference between healthy volunteers and CLTI patients. However, to enhance our diagnostic option and possibility, we've done a provocation by a walking exercise, which was the same distance for all the participants that could do the walking exercise of 150 meters and then followed by a measurement again. And what we've seen, we improved our potential of diagnostic differentiability between healthy volunteers and CLTIs concerning our AUC. Then we try to focus on the diagnostic gap of the ancobrachial index. We correlated our results according to different ancobrachial index groups and the HbO2 values. In the normal ancobrachial index, we found significantly different values compared to the other groups, like the 0.5 to 0.9 group, and those critically affected with smaller than 0.5. But the most interesting finding was that those patients with an inconclusive ancobrachial index, which is often common in diabetics or in end-stage renal disease patient, we found the worst HbO2 values with significant differences. Therefore, I think the MSOT really can close the gap of inconclusive ancobrachial index in this cohort. But I think what we found was that we investigated calf muscles and the oxygenating status as well as perfusion status in the calf muscle. This is mainly the most important thing for claudicants, as the pain in walking in this PAD cohort is in these patients in the calf muscle, and Due to MSOT, this is one of the first instruments ever we have that we really can go into depth and see the end organ of the PAD patient in the stages of claudication. Therefore, we thought we have to really focus on this cohort and trying to get deeper into the calf muscle perfusion in claudicants. This is of special interest as in daily routine, you often have really the question, what is the issue of walking impairment in this patient? Is this really in claudication, or if there's an diseased patient with PAD, but also with an arthrosis of the knee joints, for example, of the hip joints, or also of the lower back, like these radiological images show. In the end, you are not really sure where the walking impairment comes from. Is it really the joint, or is it the perfusion and the PAD? And therefore, in these patients, from a clinical perspective, it would be really interesting to have an objective tool to quantify perfusion in the muscle. Therefore, in a second study, we focused on claudicants and healthy volunteers. We've done again a study measuring MSOT in the calf muscle, but now we are doing a really straightforward provocation due to an heel rise exercise. And this heel rise exercise was performed in an exhaustive manner in both in the healthy cohort as well as in the claudicant cohort. And after this, again, a post-provocation measurement. In total, 50 patients were included in the derivation cohort, and again 50 patients in the validation cohort. And then we tried to differ based on our perfusion assessment between healthy and claudicants. Methods were that we assessed them clinically, as well as the pulse status, ultrasound investigation, ankle brachial index pre and post provocation. And for those suffering from claudication, they were additionally assessed by MRA, CTA, or DSA. Additionally, we've done a questionnaire. It's called an Vascuqual-6 questionnaire, which tries to evaluate how these patients are affected in daily life from their PAD disease, and to quantify the distance, the absolute walking distance, 6-minute walking tests were performed. Here you can see some of our measurements and MSOT images. Here in the upper part, these are the healthy volunteers after provocation. These pictures are the results of post-provocation measurement. And here in the B mode sonography, you can detect the calf muscle, and then you see the values for MSO2, this is MSOT saturation, the HbO2, the oxygenated hemoglobin, and here the deoxygenated hemoglobin. And as you can see already visually, if you compare it to the cohort on the lower side of the screen here, it's the affected PAD cohort after provocation. Here you have an increase of the perfusion and the MSO2, but you cannot really see this in the affected cohort. And if you go into detail and try to quantify it here in our ROC analysis, you see the pre-measurement values followed by the post-measurement values, and then after provocation you can really with a nearly perfect differentiability see or differ between healthy volunteers and PAD patients. Accordingly, here are the results for the HbO2 and the deoxygenated hemoglobin. If you try to correlate it with our clinical outcomes, you can see that our best value, which was namely the MSO2, correlates significantly with the ankle brachial index, the 6-minute walking test, and interestingly also the Vascuqual-6 questionnaire, which is in status of the daily affection of PAD in daily routine. Inversely, you can correlate it with the radiological findings of an affection of the vessels. To summarize, I can say that on the base of HbO2 resting values, you already can do a differentiation between healthy volunteers and CLTI patients. However, what we have seen was that the diagnostic accuracy improves after provocation. And after heel rise provocation, for example, we could demonstrate a really good distinction between claudication and healthy volunteers in terms of MSO2. This already correlates with our clinical parameters like the ankle brachial index or the questionnaire. Therefore, what we can achieve by using MSOT is a kind of paradigm shift, as we not only look on angiographic findings and radiological findings, but now we can really directly assess the muscle and therefore namely the end organ of the claudicant patients. Therefore, in future, where can we see maybe MSOT as a possible application? This can, for example, be as an objective and non-invasive monitoring method for treatment response after structured exercise therapy or after revascularization. And in terms of multiple diseased patients, like, for example, joint affection or lower back pain and PAD, you can try to achieve an objective differential diagnosis in this patient cohort. Therefore, I want to thank for your attention, and now I'm happy to take your questions.
Okay, very nice. Thank you so much, Dr. Rother. That was also an excellent talk. I took back the controls for the webinar to start our Q&A session, and we do have already many great questions. So let's start with a few. And to our audience, if you have additional questions, please feel free to type those in the question section in the GoTo tool that should be on your screen. And if we cannot get to all the questions that have come in now, we will respond to every question on an individualized basis after the webinar. So maybe to start off with general questions, how long does such an examination take?
From my point of view, it's depending on what kind of provocation you want to do. If you're doing, for example, the heel rise exercise, it's very quick because you have a quick assessment before, which lasts for about maybe 2 minutes, then doing a provocation. And after the provocation, again, you can decide how long you wanna measure, but we've seen that the best results are at about 3 minutes post provocation. Therefore, and then it's finished the assessment. So it's quite really quick. It's in about 5 to 7 minutes done.
Mm-hmm. Dr. Karlas?
Yeah, sure. For the ARSOM examination, I mean, the scan itself needs about 45 seconds, so less than a minute, so that to get this kind of image, and the preparation of the patient, another 5 to 10 minutes. So in 10 minutes, I would say more or less the examination finishes.
Mm-hmm. And maybe to come back to what Dr. Rother said with the heel raises, we have a question that asked, have you looked into different provocation methods for patients that cannot perform heel raises, for example?
Yeah, I think what led us to heel raise was exactly the issue that we really have critical ill patients, and especially the CLTI patients are often not able to do a walking exercise. And what we have seen, you can do kind of heel rise exercise already during a sitting position and having therefore a kind of provocation. So you really have to be kind of flexible in investigating your patients. But what really brought us to the best distinction between the affected and not affected patient was the exhaustive heel raise exercise, like I've shown.
Mm-hmm, mm-hmm. And how deep can you see into the tissue with this technology?
For MSOT, it's about for some centimeters, maybe until 2.5 to 3 centimeters. However, we try to be in the area of not deeper than 1.5 centimeters.
For ARSOM is 1 to 2 millimeters. So exactly how, I mean, in the skin region.
Mm-hmm. Yeah, you mentioned the skin region. So what other factors do you need to control, let's say, or consider when preparing for conducting an examination with either of the technologies?
Nothing special. I mean, the skin, of course, should be clean, but generally nothing special. We don't need any special preparation to do it. As we do an ultrasound. Yeah, it's the same.
Mm-hmm. And considering, let's say, skin tones or medications?
Yeah, that's true. I mean, there are two different things. The skin tones play a role. There are also studies showing that there is, of course, somehow reduction of the signal with darker skin tones. It depends on the populations. Here we don't have this problem because the populations are a bit different. Of course, in the States, for example, is a different cohort. This somebody should have in mind, but generally it's not. If we have in mind, then it's not a big problem. Again, we can scan patients with darker skin tones. For the medication, of course, it depends on the question. Yeah, if we have now a question about the skin microvasculature and the patient has now insulin some minutes ago, or he ate something, then this could change the result. That's why we are very aware of that, and we do the measurements in specific time points, always depending on the question.
Mm-hmm. Dr. Rother, you showed calf muscles, and I think this question goes hand in hand with that. So are you measuring multiple different areas in one muscle to look for heterogeneity within the muscle, or what is the approach?
Yeah, that's a good question. I think that has to be answered in future. We are about to answer it to get more insights of the heterogeneity of the muscles. Currently, we're doing 3D scans of the entire muscle to assess the volumetric insights and as well as different areas of the muscle. And that will be interesting to see how heterogeneous are PAD muscles. There's not much known about it.
Mm-hmm. And I think this question would be interesting for you, Dr. Karlas. So someone is asking, would you foresee that specifically for the diabetes population in general, that let's say MSOT could be used as a screening tool for early detection of the complications?
Yeah, this is exactly the point, that we now have the first studies on patients with diabetes. And exactly this would be the aim, to have like early detection of changes in the skin before the main organs are affected. So new studies should be done for the early detection first of the skin and correlation of these changes in the skin with other microvascular complications. Yeah, this is exactly our aim in the future.
And we have another question that is in the topic of standardization. So what kind of repeatability studies have been performed so far? And do you have like any comments on operator variability related to that technique?
Concerning the operator variability, we've done a small study to assess what is really needed to be known and what kind of experience do you need to get reproducible results. And what we've seen is that if you have a really personal supervision, for example, by someone who's monitoring you and helping you during the assessment, you can really start very early in this investigation and getting reproducible results. However, there's a kind of learning curve until maybe 10 assessments you have to do on your own to get reproducible results.
Yeah. Also for the ARSOM, I would say there are also done some small studies from our side. They are also published that it's quite reproducible. But again, reproducibility comes in terms of what we want to measure. So it seems to be reproducible in terms of the features that we want to extract. There are studies. There is also a study from another group which shows that MSOT also is generally reproducible in terms of hemodynamic parameters. As all handheld devices, there is always an intra-observer variability, but I wouldn't say that it's something that would concern us. Right? It's generally reproducible technology.
So we touched upon this question: what factors do you need to control or consider when preparing an examination? Someone is asking, will the fatty skin affect the accuracy of MSOT?
In terms of the calf muscle perfusion, we don't have that problem too much because the region of calf muscle is it's a good region, I would say, for MSOT because you have not too much layer in between the muscle and the surface. However, we've seen, for example, if you try to investigate the bole or intra-abdominal things, it's maybe too deep and too much fatty tissue between it. However, we had to exclude about, I think, 3 patients in total because we could not get reproducible results in the depths. So until a certain degree, I would say it's influenced by it, but it's not a big issue, I would say, when investigating calf muscle.
So we mentioned a few times the calf muscles and now abdominal muscles, and someone is asking which muscle group is measured by MSOT. So which others would maybe of importance?
Okay, which would be interesting?
Muscle. Yeah.
I think it's depending what you want to know about the muscle. But for example, what I could imagine of is, and what we've done here in Erlangen is the gluteus maximus, because they're in a specific situation of malperfusion of the iliac internal artery, for example. You can often not really say if the hip joints are the problem or is it the iliac artery stenosis in the end. And therefore, we try to establish perfusion assessment in this region. However, that's quite difficult because in this region, classically, you have a little bit more fatty layer. And so it's difficult to achieve a good assessment. But that would be interesting. But also, I think, Karlas, you've done studies in the region of the arm.
Of the arm as well, yeah. It depends, as Dr. Rother said, it depends on the application, what we want to see. We have done also studies in the region of the arm, brachioradialis muscle, or endothelial function within the muscle, with good results generally. Yeah, I mean, again, it depends on the application. The muscle generally is a good target organ because it's not very deep, depending again on the configuration of the body. That's why I think there are many different positions where somebody could scan.
Maybe one last question. Someone is asking for Dr. Rother and you, Dr. Karlas, both to comment on the accuracy and efficiency of the device. So, Dr. Rother, maybe you can start off.
I think it's difficult to say in the end because we are in a not too advanced stage of course of study situations. These are the first studies, both I think from Angelos and me, reporting on these topics. However, the accuracy of and the diagnostic certainty, I would say, to differ between healthy and claudicants, for example, or healthy and CLTI is really good and promising for the future.
Yeah, this is also my opinion. Yeah, this is also my opinion. We have now the first studies. I mean, if we want now to have the accuracy, for example, if the question would be, are we accurate in how we represent the microvasculature of the skin, then biopsies should be done of the exact position, and then histological analysis, and these are studies that are going to be done in the future. If we want to talk about accuracy on the detection of diabetes in the skin, then we have 80% in our study, for example. So these are things that should be done in the future, and this is what we're trying to do also in the studies.
Great. So I think with that, we can conclude the webinar. I would like to thank you both, Dr. Karlas and Dr. Rother. We really appreciate your great talks, and I, for one, really enjoyed the Q&A session. We will be in touch with our audience the next few days with the recording, and thank you all very much for your time and attendance today. Goodbye.
Thank you very much as well. Bye-bye.